Hey, good morning, guys. So I have your week 3 update here. First of all, let's start with our shout outs. Kayla, you did a great job on improving things from last week. Maria, Anjanette, and Alpha, and then Scott Lowe and Bravo, you guys did a great job of including some outside original literature into your posts. So good job there. So this week we talked about adhesive capsulitis. Diagnosis is really kind of vague and ill-defined. You can have either primary or secondary, and that may be something that goes into your history taking that may prove beneficial. And then taking that history in detail on how things have changed since the condition has started may be helpful in diagnosing this. And we think maybe if we can get to an end feel and feel that that thing is tightening up, but that's not going to be present until later stages. So for treatment of our adhesive caps, we read Boyle's, the translatory manipulation under anesthesia, and that's the pictures that are below from the Playcheck article. And while our patients may not tolerate these manipulations necessarily as they were done in the articles, that we may be able to progress where we can get them in some of these positions and mobilize more aggressively there and as their irritability lowers. As far as joint mobilizations, we have evidence from Johnson saying probably posterior glide is more beneficial than anterior glide. Vermeulen found that higher grades had the very, very slight nod over lower grades, but those weren't really matched to patient presentation, so that may have been one reason that there was just modest results there. And then Seelig found that adding our mobilizations into stretching is much more beneficial than just stretching alone. And because it's kind of one of those conditions where it will involve many structures around it, we also can use some of this lower level case study evidence and dry needling and thoracic manipulation to perhaps help those patients along and help us in treating their primary issue, which would be that capsule. So for our proximal humerus fracture, early mobilization seems to be key. Less than 3 weeks would be early mobilization after. Definitely too long, as long as the fracture is stable. These patients likely have a very pathoanatomical picture in their mind of something broken, and that just needs to heal. So we do have to be very good at our education and letting them know that we're not going to hurt them, that this has been shown in the literature to be the most helpful thing for you. And then based on the anatomy here, we have the nerve injury is actually pretty common. And Visser found that in those with displaced fractures, that it was around 80% had concurrent nerve injuries, and then those non-displaced, still 59% had nerve injury. So and they also state that it is pretty hard for our exam to come up with this diagnosis of a nerve injury, and so likely treatment with nerve glides is maybe something that would become diagnostic in your test, treat, retest model. So for next week, shoulder instability, rotator cuff and biceps tendon dysfunction. And then don't forget that your rough draft of your group project is due by Saturday night. And any other questions, just feel free to reach out to me, and I will see you guys on the boards next week.